Welcome guys, we're going to be talking about Tetrallogy of Fallot. So we started by talking about a case of a 6-month-old female patient born term with no prior history of illness, who presented to us with a 3-month history of fast breathing, tiring easily when breastfeeding, bluish purple discoloration of the hands and feet when crying, and intermittent cough which was worse at night. There was no family history of atopy. There was no history of choking on breastfeeding. On examination, there was no dysmorphism. The patient was cynosed centrally and peripherally, was plethoric with grade 3 clubbing of the toes and fingers, and the patient had a single second heart sound. Then in pulmonic area, the pansystolic murmur, which disappeared when the patient cries. Saturation was low and was rising to a maximum of 80% on oxygen. An echocardiography was done which showed Tetrallogy of Fallot. There was no pulmonary hypertension demonstrated on echo. The full blood count had a hemoglobin of 13. The hematocrit was 52.3. It was mildly raised. The mean corpuscular volume was 63.5. So the patient did a microcytic anemia or microcytosis. Then the platelet was 549 and the white cell count was 13.7. On the following day, post-admission, the patient became bradycardic, cynosed, heavily cynosed, and was gasping. We transferred this patient to ICU. We gave the patient a bolus of IV, normal saline, then oxygen therapy, and propranolol. Then the patient improved and was discharged from ICU a day later. So the patient now managed to go home and is awaiting surgical correction. So I'm going to discuss Tetrallogy of Fallot. Tetrallogy of Fallot is a congenital cyanotic heart disease which is characterized by a ventricular septal defect, an overriding aorta, a pulmonary stenosis, and right ventricular hypertrophy. So the clinical presentation, the patient usually present with cyanosis. They could have a growth failure and poor feeding, and they can present with hypercyanotic spells which are common between the age of 2 months and 6 months. And with this hypercyanotic spell, like this patient of ours who became cynosed and wanted and need to go to ICU, this was because this patient was actually having a cyanotic spell, and they managed to break the spell by treating it with IV fluids and propranolol, as well as oxygen, and putting the patient in a knee to chest position. So on examination of a patient that is Tetrallogy of Fallot, you see that the patient will have cyanosis, they will have clubbing, they will be plethoric. This is because they have a high hematocrit, and the murmur that you hear is a pulmonary stenosis murmur. So it's a pulmonic murmur, like this patient is a pulmonic murmur. The ventricular septal defect murmur is usually not heard because the VSDs are usually large, and heart failure is not a feature that we expect with Tetrallogy of Fallot. Then Tetrallogy of Fallot is associated with certain syndromes like Down syndrome, Dye-George syndrome, and Alagille syndrome. So what this means is that Tetrallogy of Fallot can also be associated with some dysmorphism on examination. Causes of heart failure in Tetrallogy of Fallot: it's possible to get heart failure which can occur because of iron deficiency anemia, because this patient become plethoric. When patients are hypoxic, they tend to compensate by increasing erythropoietin production, and this leads to more red blood cells, and eventually the iron is used up. So patients with Tetrallogy of Fallot, because they're cyanosed, they need iron supplements. And these patients, because they have congenital heart disease, they are also at risk of infective endocarditis. So a chest X-ray of a patient that is Tetrallogy of Fallot shows a boot-shaped heart. So this is because of the right ventricular hypertrophy, which causes the apex to be pointing upwards. Then the lung fields are oligemic. This is because of the pulmonary stenosis, which means there is reduced pulmonary blood flow. An ECG would have a right axis deviation and right ventricular hypertrophy. So treatment is surgery and a blood lock shunt done, usually done after the neonatal period and before 1 year.